Hi, my name's Kath Bunting. I'm going to talk to you today about physiotherapy after upper abdominal surgery and specifically the prevention of post-operative pulmonary complications. So before we get started, just to give you a little bit of a background about upper abdominal surgery. So upper abdominal surgery is any surgery that involves an open incision that extends above the umbilicus, so above the belly button, and typically performed to allow surgeries to take place on the structures in the gastrointestinal tract. That could be up as high as the esophagus, it could be down as low as the rectum. So a huge different variety of surgeries would actually fall into this category of upper abdominal surgery. So it's actually to do with where the incision is rather than where the organs are that are actually being operated on. And why do general surgery patients need physiotherapy? So as with all patients undergoing surgery, general anaesthetic tends to knock around the lungs a bit. They don't particularly like it. The patient tends to be in a recumbent or supine position, which has effects also on the lungs. And when you add to that the fact that the abdomen has been opened up, the surgeon's had his big hands in there pushing and shoving things around, the diaphragm gets pushed upwards towards the head and actually compresses the lung tissue. Some of the surgeries actually will require just one lung to be ventilated rather than two lungs, so that can have significant effects on the lungs as well. So in general, it's one of the higher surgery types for post-operative pulmonary complications. And some of the things that contribute to that are reduced functional residual capacity and consequential atelectasis and hypoxemia. We can get hypoventilation and lack of sighing from the ventilator, which causes a loss of surfactant and a higher closing capacity that will compound your atelectasis and hypoxemia. Your mucociliary clearance system will be affected, so it becomes dry because the anaesthetic gases and there's actually a reduced beat frequency of the cilia. If high levels of oxygen are used, you get this absorption atelectasis. And then because of the anaesthetic, also because of the medications after surgery, you get this decreased ventilatory drive. We may see respiratory muscle insufficiency, which will be significantly exacerbated if our patient's in pain. And yeah, there's always the risk when you have a patient having a general anaesthetic that there might be some aspiration. In terms of the cardiorespiratory physio impairment list, so I drive all my treatments coming off the back of this impairment list. So if we identify what our impairments our patient has, then we know what treatments we can apply to help the patient. So what do we normally see in our upper abdominal surgery population? Well, pain is often a feature, and that's one of the first things I will address when I walk in the room. The reason I address it very quickly is because if you have pain, you're going to have reduced lung volumes and then you're going to have impaired gas exchange. So it makes the other problems significantly worse if you don't deal with it. It's a huge area and not the focus of this presentation today. So we're going to focus on our next one, which is our reduced lung volumes. Mainly existing because of a combination of factors. So the patient being in a supine position, having anaesthetic agents, having, as I said before, that's the surgery in the upper abdominal region, which will cause displacement of the diaphragm. And there's research that has shown that the higher the incision, the closer the incision to the diaphragm, the more effect on the diaphragm, which seems intuitive. As a consequence of your lung volumes, you're going to see impaired gas exchange. Other things that you might see, but I wouldn't expect to see in a standard patient, were impaired airway clearance or dyspnea if you don't get on top of the problems early enough. And then long-term, which is a whole other issue, is whether patients have a long-term reduction in exercise tolerance as a consequence. And one thing I want to point out at this point here is, even though your patient will probably present with some kind of combination of these main impairments, so your pain, reduced lung volumes, and impaired gas exchange, what we're really trying to do is prevent them becoming clinically significant. So when they become clinically significant, we get this condition called a post-operative pulmonary complication. So this is classified as an identifiable disease or dysfunction that is clinically relevant and adversely affects the clinical course. So a fairly vague definition, and that probably contributes to the high variability in rates of this complication. But even with the variability, we're looking at rates somewhere between 9 and 40% of upper abdominal surgery patients actually having a post-operative pulmonary complication or respiratory compromise that is significant enough that we can say it's adversely affected their clinical course. And the things we see increased length of stay, we see increased ICU readmissions, we see increased costs of care, all associated with these impairments. So, and it's arguably the most significant complication after upper abdominal surgery. So it's definitely something we want to prevent. And when we look at the rates, somewhere between 10 and 40%, so that's between 1 and 4 out of every 10 get one of these complications. So if we can do anything to actually reduce those rates, then that's definitely what we want to do. So how do we do this? How do we stop our patients getting these post-operative pulmonary complications? So, well, this is our little recipe that we provide to our patients after upper abdominal surgery. So day one, they'll do their deep breathing exercises. They'll go up to a chair. Maybe they'll mobilize a short distance with assistance. Day two, progressing that level of assistance, carrying on with our exercises and up to chair. And up at day three, probably more realistically, day 3 to 5, increasing mobility to 40 meters, ensuring they're independent, possibly a stair assessment, and possibly discharging them home. So that's really our kind of recipe. Some places you'll still find patients being given an incentive spirometer, for example, in place of the deep breathing exercises, although the evidence is now fairly conclusive that they are no more effective than just asking your patients to do deep breathing exercises. And based on the fact that they actually cost more money, and actually confer a somewhat infection control risk, then I would certainly advocate not prescribing them for your patients. All right, so how does this fit in with evidence-based practice? So I think we need to understand, first of all, what evidence-based practice actually is. So most famous definitions from David Sackett in 1996. This was published in the British Medical Journal, and he's described evidence-based practice as the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of the individual patient. So it means integrating individual clinical expertise with the best available external clinical evidence from systematic research. So what he's really saying is, where there's good research and good evidence, then we need to utilize that and we need to let it guide our practice, but not entirely at the expense of our clinical expertise. And certainly where there's gaps in evidence, that's where our clinical expertise will definitely have to fit in. Now, not much has changed in terms of definitions since then, but what we have seen is a much more of a move towards the patient values, the patient preferences. And as physiotherapists, I think we need to consider the patient goals. So the patient goals are really, really important to us as physiotherapists. And we're going to touch on that when we look at a case study later on. So let's look at evidence-based practice. Let's look at these things. So let's start with the best research evidence. So in terms of our early mobilization, what do we know about early mobilization in patients after upper abdominal surgery? Well, we know it's good. This is absolutely conclusive. So getting a patient up and out of bed early after surgery is essential. But what does early mobilization mean? So early mobilization actually consists of upright positioning and ambulation away from the bedside. Okay, so those two are kind of lumped in under this early mobilization banner, if you like. And it has been shown in numerous studies to be effective in reducing post-operative pulmonary complications. So we know bed rest is bad, being up out of bed is good. A study by Haynes and colleagues in 2013 actually found that for every day that patients don't mobilize away from the bedside, they are 3 times more likely to develop a post-operative pulmonary complication. Now, remember, this is just one study showing this, but it certainly is enough to raise our suspicions that it's not just the upright positioning itself that is causing this protective effect from pulmonary complications, that the actual mobilizing away from the bedside is offering additional benefit on top of that upright positioning. So that's really key when we're deciding what we're doing with our patients, and that's why most of us are walking our patients away from the bedside as well as getting them up out of bed. But what about deep breathing exercises? All right, so what would intuition tell us here? So we know that lung volumes are reduced post-operatively. So deep breathing exercises should help, right? Well, it seems that they actually may not help as long as early mobilization is undertaken. When I say early mobilization, this should say early ambulation. So as long as you're mobilizing your patient away from the bedside, it may be that you don't need to actually be adding in deep breathing exercises. So is this conclusive? Probably not yet. There's a couple of studies now, so Mackay and colleagues, Silva and colleagues have both shown very similar results in that as long as you've got your early mobilization, that the deep breathing exercises aren't required. But I would say probably need a little bit more evidence to back up our claims in this one before we can say, before we can be confident to dismiss deep breathing exercises out of hand. We also need to consider what we don't know. So what we don't know is the dose. We don't know how much we should be doing. So we know upright position is good, but not for how many hours per day. There was a study done in 2007, or study published in 2007, Browning and colleagues, and they actually looked at how much time upper abdominal surgery patients were spending upright in the days after surgery. And they actually found quite alarmingly, on not just the first, or the second, or the third, but up to the fourth post-operative day, the amount of uptime, so time spent in an upright position, could be counted in minutes, not hours, minutes. And something like 3 minutes on average for first post-operative day. So I'd like to think in the last 10 years that those numbers have improved, but we just don't have recent data to support that claim that it has. And it's really difficult to be able to say, well, you must be spending a much more time upright when we don't actually have a dose for us. We don't know yet how many hours per day upright is the best amount. We also know that walking our patient is good, but what we don't know is how far we should be walking them, how intense that walking should be. So there's a lot, there's some information that we do know. So we do know now. So being upright is good, walking is good. Deep breathing exercises, possibly not. But we don't know a huge amount. There's a vast amount that we really don't understand about this particular area. And that is where we need to actually call on our clinical expertise. So moving on to the next step of deciding how to manage our patients in that evidence-based framework, and that's our clinical expertise, which is, it's fine for me to stand up here and say I've got many years of working with these patient populations, but what I don't have, but what you guys don't have is that clinical expertise. As students coming in to this work environment as junior physiotherapists, as you will be, you don't have that clinical expertise. So what do you call upon in this situation? Well, in this situation, you're actually quite lucky. So Susan Hanekom is a very well-known respiratory physiotherapy academic. She's based out of Stellenbosch University in South Africa, and she actually got together with a group of very qualified and experienced physios, and they put together some guidelines for physios to follow in light of the lack of conclusive evidence to guide our care. So what they've actually gone as far as to develop this really in-depth, detailed algorithm on how to manage these patients. And these are consensus guidelines, so obviously not all based on actual hard evidence. A lot of it is just based on these guys saying this is what we think is best based on the knowledge that we have and the experience we have. So these are the recommendations, and I've just picked the main ones out of this paper. So sitting out of bed for a minimum of 1 hour, twice daily. Walking at least 5 meters on the first post-operative day. Patients that are showing a PF ratio of less than 300, so that's patients who are starting to show signs of possible acute lung injury. Deep breathing exercises should also be performed for them. And airway clearance techniques as required. But what's really interesting is they start talking about from the second post-operative day or from subsequent visits from that first post-operative day, they start talking about an intensive mobilization program. So they're starting to say you should be mobilizing your patients at an intensity of at least 6 out of 10 on the modified Borg scale. and aiming for 3 times daily. So why are they coming up with this theory that we need to be mobilizing our patients intensively? Like, they've just had big surgery, so would we not want to be allowing their bodies time to rest and heal? Well, when we consider the physiology, so what we're trying to do is improve our lung volumes. So we've identified that reduced lung volumes are a real significant contributor to the development of post-operative pulmonary complications. We get our patients upright, we improve their FRC, we know that, that's great. But what will allow us to confer additional benefit on top of that? What will allow us to cause that natural deep expansion of our lungs? Well, pushing our patients, making them exercise. So what happens when you exercise? When you start exercising, naturally your body will start breathing deeper. Okay, so this is a natural way of causing this change and trying to overcome some of the changes that are associated with the anesthetic, with the mechanical ventilation, and with the recumbency. So that's why they're making this recommendation. All right, so now we have our evidence base, we have our clinical expertise from these consensus guidelines. Now we have to apply it to the patients. Remember this, the patients really center in this, and this is the key. We're actually trying to provide outcomes for this patient. So we've got a 61-year-old male, experienced some mild rectal bleeding, diagnosed with colorectal cancer, which has now spread to his liver. 3 months ago, he underwent a right hemicolectomy. He's had some chemo, and he's now come back to have his liver resected. All right, so this is our patient. Let's say his name is Jack or John or something. All right, so we're going to apply our recipe to Jack or John. So day 1, we're going to do our deep breathing exercises, possibly. We're going to get him up to the chair. We're going to mobilize him a short distance. Day 2, we're going to do some deep breathing exercises, try and increase his distance. Again, put him up to the chair. And then day 3 to 5, probably really looking to increase mobility to 40 meters, making sure he's independent, possibly a stair assessment, and possibly discharge. So I'd say that sounds fair enough. But let's consider 2 different patients here. So these are both 61-year-old males. They're both coming in for their liver resection. Both got the same back history. One's called Jack, one's called John. Let's look at their cases. So Jack, smoker, moderate alcohol consumption. He has a past medical history of hypertension, coronary artery disease, peripheral vascular disease, and diabetes. Exercise tolerance, 50 meters on the flat, limited by leg pain and breathlessness. So could be from his heart, could be from just a lack of fitness, leg pain, possibly some intermittent claudication. John, non-smoker, non-drinker, past medical history, hernia repair 20 years ago. Apart from that, nothing else. Exercise tolerance is unlimited, regularly competes in triathlons and running events, and in fact, the week before he was diagnosed, he completed a 100-kilometer ultra marathon. So how does our recipe stack up now? Even if we go back to the consensus guidelines, day 1, walk our patient 5 meters. How much of a challenge do you think that would be for Jack compared to John? And if we're considering that we want a physiological response in our patient, can we apply the same recipe to 2 very different patients without consideration of their backstories and without consideration of their goals? Well, I don't think we can. We need to look at the individual patient. And that's why it's really important, instead of following a recipe, and instead of even creating a recipe, we need to understand why we're doing what we're doing. And we need to understand what we're trying to achieve. So John is going to have to do a lot more than Jack to get that cardiorespiratory response. So that is why they have recommended in those guidelines an RPE scale of 6 out of 10. So for Jack, that might be just a transfer to the bedside chair or a shuffle to the end of the bed and back. For John, he might be doing step-ups and squats. And that could all be post-op day 1. So I think you need to consider, first of all, what you're trying to achieve. The evidence can tell us a great deal. The evidence can tell us what treatments are effective. But when we're considering how to apply those to your patient population, we need to understand why we're doing what we're doing. All right, so let's summarize what we've talked about. So we do have some evidence in this area, but not a huge amount. The evidence says upright is best. We know upright's best. It's looking like ambulation on top of upright is also best, possibly to a level of 6 out of 10 on the Borg RPE scale. It's looking like deep breathing exercises probably don't confer any additional benefit on top of early mobilization, but we really don't know what their place is if a patient isn't able to participate in early mobilization, which is an important consideration. And we don't know dose. We don't know how much of these we need to be giving our patients. And that's really an important consideration that we need to consider for future research. So clinical expertise seems to be guiding us towards higher intensity to really elicit a cardiorespiratory response to exercise. But as of yet, we don't really know how effective that is. And of course, we can't forget our patient values, preferences, and our patient goals. So what does your patient want to achieve and what are they motivated to achieve? Because that is ultimately going to guide how successful you are in applying your treatment to your patient. And so that's how we perform evidence-based practice. So we do the best with what we know, and we strive to discover what we don't. And I really hope that I have informed you and somewhat inspired you in the area of post-operative upper abdominal surgery care in terms of physiotherapy.